Welcome to our video on rheumatoid arthritis and osteoarthritis. Let's begin. We will be covering two topics, rheumatoid arthritis and osteoarthritis. So let's begin with rheumatoid arthritis. In rheumatoid arthritis, we will cover the introduction, clinical features, diagnosis, and treatment. Let's begin with the introduction. Rheumatoid arthritis is a chronic inflammatory autoimmune disease. It most commonly affects the peripheral joints. It is seen more frequently in women around 30 to 50 years old. It has an association with HLA-DR4, which is also related to IgA nephropathy and polymyalgia rheumatica. Rheumatoid arthritis is considered a risk factor for septic arthritis, as it favors bacterial colonization. Also, most of the medications used for rheumatoid arthritis suppress the immune system, making infections more likely to occur. The etiology of the disease is uncertain. It may be caused by infections like Epstein-Barr virus, parvovirus, human herpes virus 6, but genetic predisposition is necessary. The pathogenesis of the disease involves activated CD4 positive T cells, which release the pro-inflammatory agents like tumor necrosis factor. The inflamed synovial cells then express an antigen that stimulates B cells to produce rheumatoid factor, which is an antibody against the Fc portion of IgG. The rheumatoid factor then joins IgG to form immune complexes. Immune complexes activate the complement system to produce C5a, which is a chemotactic agent for neutrophils to enter the joint space where a pannus is formed eventually. A pannus is granulation tissue formed by fibroblasts, which releases cytokines that eventually destroy the cartilage. When it comes to the clinical features, rheumatoid arthritis presents with articular and extra-articular features. So let's start by describing the articular symptoms. Rheumatoid arthritis commonly presents with symmetric involvement of the second and third metacarpophalangeal and proximal interphalangeal joints. Due to the inflammation and eventual pannus formation, patients complain of pain and swelling of the affected joints. Patients also present with morning stiffness or rigidity for more than 1 hour. This morning stiffness occurs after a prolonged period of inactivity and improves throughout the day. There are some classical hand deformities shown by this disease. They include swan neck deformity, boat ear deformity, and ulnar deviation of the metacarpophalangeal joints. Let's go through them. Swan neck deformity presents with flexion of the distal interphalangeal joint and extension of the proximal interphalangeal joint, and these joined together form what looks like a swan neck. Boutonniere deformity presents with an extension of the distal interphalangeal joint and flexion of the proximal interphalangeal joint. Boutonniere means buttonhole, which is the shape the joint takes. And lastly, the ulnar deviation of the metacarpophalangeal joints. Notice how the joints bend or deviate medially as if they're pointing to the ulnar bone. Other articular findings include the entrapment of the median nerve, which results in carpal tunnel syndrome. Rheumatoid arthritis of the cervical spine presents with subluxation of the atlantoaxial joint located between C1 and C2 vertebrae, which can be particularly dangerous. This can cause compression of the spinal cord or the vertebral artery, leading to a stroke. Now, let's continue with the extra-articular features. Besides the constitutional symptoms like malaise, anorexia, fever, and weight loss, there are multisystemic symptoms as well. Starting with the cutaneous presentation, rheumatoid nodules are firm subcutaneous lumps which can be present on the extensor surface of forearms and lungs. These nodules, mixed with pneumoconiosis, are called Kaplan syndrome. Among the cardiovascular findings, there is fibrinous pericarditis and aortitis. Small vessel vasculitis can also be encountered, and it correlates with very high titers of rheumatoid factor. Pulmonary involvement in rheumatoid arthritis presents as chronic pleuritis with effusions, as well as interstitial fibrosis. As for the hematologic findings, there is anemia of chronic disease, which is mild, normocytic, and normochromatic anemia. Thrombocytosis can also be seen in these patients. Felty syndrome, which is a triad of rheumatoid arthritis, autoimmune neutropenia, and splenomegaly, can be present. But these occur relatively late in the disease. There are ocular involvement findings, which include scleritis or episcleritis. Scleritis is the inflammation of the sclera, and episcleritis is the inflammation of tissue between the sclera and the conjunctiva. Finally, there can be popliteal cyst, also called Baker cyst, located behind the knee joint. It is usually caused by the joint producing too much lubrication fluid, causing a bulging bursa in the popliteal fossa. Please notice the subcutaneous or under the skin nodules indicated by arrows. Here is an illustration of a Baker cyst. Please notice the cyst formation behind the gastrocnemius muscle. As we mentioned before, this is bulging bursa in the popliteal fossa. Pain is uncommon, but it can cause swelling on the area. So let's read this question. It's a 57-year-old woman brought to the hospital by emergency medical services after she was struck by a car. She was thrown 2 meters from the road. Her past medical history is significant for rheumatoid arthritis treated with methotrexate. She is somnolent and reacts only to painful stimuli. Her vital signs include a blood pressure of 70/50, heart rate of 140, and respiratory rate of 17. Her Glasgow Coma Scale score is 7. The physician decides to intubate her. What imaging study should be performed before intubating this patient? This patient with a past medical history of rheumatoid arthritis was involved in a motor vehicle accident. Her vital signs reveal severe hypotension and tachycardia. Glasgow Coma Scale of 7 prompts the physician to intubate her. However, before the patient with rheumatoid arthritis is intubated, we should perform a lateral cervical spine X-ray to check for atlantoaxial instability, which is commonly seen in rheumatoid arthritis. If the patient has atlantoaxial instability, intubation might cause the subluxation of this joint and compression of the spinal cord that is potentially lethal. Other diseases characterized by atlantoaxial instability include Down syndrome, ankylosing spondylitis, and juvenile idiopathic arthritis. Now let's discuss the diagnosis. Initial blood tests show elevated erythrocyte sedimentation rate. When serological tests are performed, high titers of rheumatoid factor are seen, which is directly proportional to the severity of the disease, but nonspecific. This is because the rheumatoid factor is also present in a very low percentage of the healthy population. The physician also looks for anti-citrulline protein antibodies, which are highly specific compared to the rheumatoid factor. Synovial fluid analysis shows cloudy yellow fluid and white blood cell count of over 5,000. This, however, can be nonspecific due to similar findings in gout, pseudogout, and Reiter syndrome. On X-ray, there is narrowing of the joint space along with bony erosions. On this X-ray, we can see joint space narrowing due to rheumatoid arthritis, specifically ankylosing fusion of the carpal bones. The main goal of treatment is to prevent the disease progression, as well as applying measures to help the patient remain functional. Exercise is a great way to maintain muscle strength and range of motion. For acute attacks, non-steroidal anti-inflammatory drugs are used. Corticosteroids can be used if the NSAIDs aren't enough to manage the pain. As always, please note that corticosteroids are preferred as a short-term treatment but should be avoided in the long-term use. Early treatment with disease-modifying anti-rheumatic drugs minimize the long-term damage to the joints and slows the progression of the disease. These drugs should be started at the time of diagnosis due to the slow onset of action, as they need 6 weeks or longer to achieve the desired effect. Methotrexate is the most commonly used medication. However, it can cause bone marrow suppression, so it should be administered with folinic acid. Tumor necrosis factor alpha blockers like etanercept or infliximab are used if the disease-modifying anti-rheumatic drugs are ineffective. These could result in reactivating tuberculosis, so a purified protein derivative or PPD test should be done prior. In severe cases, surgery is needed to decrease joint pain. This includes synovectomy or removal of the joint as well as joint replacement. However, these surgical approaches do not prevent the disease progression. All right, now let's do a flash quiz. A 48-year-old woman comes to the physician due to generalized joint pain for the last 6 months. She feels joint stiffness throughout her body for about an hour in the morning. Stiffness resolves once she goes out for exercise. She also complains of frequent infections for the past year. She has been hospitalized 5 times due to community-acquired pneumonia over the course of a year. Physician exam reveals pain and warmth in proximal interphalangeal joints and metacarpophalangeal joints bilaterally. An abdominal exam reveals splenomegaly. The complete blood count is significant for an absolute neutrophil count of 1,000. Which condition best explains this patient's findings? So the patient has a generalized inflammatory joint pain evidenced by prolonged morning stiffness that resolves with exercise. There is symmetric pain and warmth in small joints of the hands. These findings in a middle-aged woman suggest rheumatoid arthritis. She has a past medical history of frequent infections and her absolute neutrophil count is less than 1,500. This is consistent with neutropenia. Finally, abdominal exam reveals splenomegaly. A triad of rheumatoid arthritis and neutropenia and splenomegaly is known as Felty syndrome. Let's continue with osteoarthritis. We will discuss the definition, etiology, clinical features, diagnosis, and management of osteoarthritis. So let's start with the definition. Osteoarthritis is categorized as the most common disabling non-inflammatory joint disease. It's defined as progressive degeneration of the articular cartilage due to wear, tear, and hypertrophy of the bone. It typically targets weight-bearing joints like the hips, knees, and ankles. Also, it is mostly seen in patients over 65 years of age. Let's move on to the etiology. Patients with osteoarthritis have a genetic predisposition. Other conditions that may predispose to the disease include excessive joint loading, typically seen in manual laborers or athletes, repetitive microtrauma, which is usually due to the patient's occupation, as well as fractures. Finally, some deposition diseases can cause damage to the chondrocytes or make the cartilage stiffer, thus predisposed to osteoarthritis. For example, hematochromatosis, Wilson's disease, and gout. On the clinical features, pain is usually the most common complaint, and it is aggravated with movement of the joint because the osteophytes irritate the synovial lining and cause rubbing bone on bone. An osteophyte is an abnormal bone projection that grows along the edge of a bone. During examination, there is joint stiffness commonly seen in inactive joints. This is why the patient complains of the stiffness when waking up in the morning. Please note that when compared to rheumatoid arthritis, the morning stiffness in osteoarthritis is less than 1 hour and it improves with rest. There is also a limited range of motion seen in late stages due to the bony enlargement of joints. Patients do not present with any systemic symptoms, joint erythema, or warmth. However, there can be joint swelling indicating inflammation. When it comes to the hand involvement, there are 2 types of nodes. The distal interphalangeal joint enlargement called Heberden nodes, and the proximal interphalangeal joint enlargement called the Bouchard nodes. Let's take a look at these. So let's look at this image. We can see the formation of distal interphalangeal joint nodes called Heberden nodes, and the formation of proximal interphalangeal joint nodules, also called Bouchard nodes. These are classic findings in osteoarthritis. To make a diagnosis, a plain radiograph should be the initial test. Some of the findings would be joint space narrowing because of the loss of cartilage and osteophytes. There is also sclerosis of end plates, also called subchondral sclerosis, and cysts. Blood tests will be normal. Spinal MRI would be indicated only prior to surgery to check for the presence of degenerative changes. Finally, let's note that the diagnosis can be made clinically if the patient has typical presentation and is more than 45 years of age. Here's an X-ray image of the hip showing severe osteoarthritis. Please notice the bone enlargement, which leads to narrowing of the joint space and eventual decreased range of motion. There can also be tenderness on palpation. When it comes to the treatment, supportive measures are taken. Heat application and decreased weight-bearing exercises are the first measures taken. Other ones include the use of a cane or crutches. Non-steroidal anti-inflammatory drugs are used for pain control. Intra-articular corticosteroid injections are used if the pain is more severe. Viscosupplementation may also be provided. It is the injection of a hyaluronate into the joints. a glycosaminoglycan with the function of increasing the viscoelastic properties of normal synovial fluid. Recent studies show good pain relief, but results are variable. Lastly, joint replacement should be considered if pain control is not achieved. A 52-year-old woman comes to the physician due to pain and stiffness in her joints for the last year. Her movements are restricted mostly in the morning, but after taking a shower and doing morning workout, her joints feel less stiff. The physical exam reveals warmth and tenderness of proximal interphalangeal, metacarpophalangeal, and knee joints. Testing for rheumatic factor is strongly positive. The titer of an anticyclic citrullonated peptide is 1 to 2,000. Which medication, delaying the progression of her underlying disease, should be initiated in this patient? This patient has an inflammatory joint pain in her proximal interphalangeal, metacarpophalangeal, and knee joints evidenced by morning stiffness that resolves with exercise. Testing for rheumatic factor is strongly positive, and the titer of an anticyclic citrullonated peptide is 1 to 2,000, which is elevated. All these findings suggest rheumatoid arthritis. The medication that delays progression of rheumatoid arthritis and should be initiated in this patient is methotrexate. Let's take a look at this table. Everyone loves a good summary table. Starting with osteoarthritis, it is a degenerative joint disorder caused by mechanical damage. The articular cartilage destruction is due to wear and tear. Amongst the risk factors included, there is advanced age, obesity, and previous joint trauma, and female gender. It presents with pain at the end of the day that improves with rest. There is asymmetric joint involvement, and there are no systemic symptoms. Heberden and Bouchard nodes are also found in patients with osteoarthritis. On imaging, there is joint space narrowing, osteophytes, and subchondral sclerosis and cysts. As for the treatment, NSAIDs are used for pain control or intra-articular glucocorticoids if the NSAIDs are not sufficient. Lastly, lifestyle changes are encouraged. Now, continuing with rheumatoid arthritis, it is an autoimmune disease that causes formation of pannus and results in erosion of the articular cartilage and bone. It is mostly seen in females. There is an HLA-DR4 association, and anticyclic citrullonated peptide and rheumatoid factor are found in these patients. It presents with pain and morning stiffness for over an hour. The morning stiffness improves with use, compared with osteoarthritis, which improves with rest. There is symmetric joint involvement, extra-articular manifestations, and systemic symptoms. Swan neck and boutonniere deformity, as well as metacarpal and proximal interphalangeal joint enlargement, can be found on the physical examination. Please note that in osteoarthritis, the distal interphalangeal joints are commonly involved, compared to rheumatoid arthritis. On imaging, there is joint space narrowing and osteophytes. For the treatment, NSAIDs, glucocorticoids, disease-modifying anti-rheumatic agents, and TNF-alpha inhibitors are used. All right, let's do one more flash quiz. A 78-year-old man comes to the physician due to worsening pain in his knees for the last 5 years. His knees feel stiff for about 20 minutes in the morning, and then he regains his normal mobility. His vital signs include a temperature of 36 degrees Celsius, a blood pressure of 135/80, and a heart rate of 72. Physical exam reveals slightly enlarged, non-erythematous, non-tender knee joints. Distal and proximal interphalangeal joints also seem enlarged. The patient's BMI is 35. The knee X-ray reveals joint space narrowing, subchondral sclerosis, and cysts, and the lateral bony outgrowths from the femur. Which of the following is the best management option for this patient? A. Acetaminophen. B. Ibuprofen. C. Intra-articular corticosteroids. Or D. Joint replacement surgery. This patient presents with a short morning stiffness and worsening knee pain. Physical exam reveals slightly enlarged, non-erythematous, non-tender knee joints. The distal and proximal interphalangeal joints are enlarged too. He is obese. The knee X-ray reveals joint space narrowing, subchondral sclerosis and cysts, and the lateral bony outgrowths from the femur, namely osteophytes. All of these findings are consistent with the diagnosis of osteoarthritis. The first-line pharmacologic management option in osteoarthritis is NSAIDs, for example, ibuprofen. It is used for pain control. Therefore, the correct option is B. This slide reminds us of the treatment options for osteoarthritis. So let's discuss why the other options are incorrect. Option A, acetaminophen, is incorrect because although it is an analgesic, it has been shown to be less effective than NSAIDs in the management of osteoarthritis. Option C is incorrect because intra-articular corticosteroids are usually used for osteoarthritis resistant to NSAIDs. Option D, joint replacement surgery, is incorrect because it is the last resort for the management of osteoarthritis. Pharmacologic management should be attempted before surgery. And that concludes our lecture on rheumatoid arthritis and osteoarthritis.